Hello, and welcome to the ACR Journals On Air podcast. I am your guest host, Bharat Kumar, filling in for Vicky Shamagan. For many of us, acetaminophen, or paracetamol, is a trivial medication, something to help with everyday aches and pains. It's likely that we've been taught that throughout the course of our medical education. But is this received wisdom truly accurate? We are incredibly grateful to have Dr. Kaur and Dr. Abhishek here to discuss their study on the safety of acetaminophen. Let me introduce them real quick. So Dr. Jaspreet Kaur is a research fellow at the University of Nottingham. She obtained a Bachelor of Ayurvedic Medicine and Surgery from Baba Farid University of Health Sciences, Punjab in 2006. She worked as a resident doctor for 4 years. Then she completed a master's in public health from Oxford Brookes University in Merit in 2010. She also holds a postgraduate diploma in healthcare management. She completed her PhD in academic rheumatology from the University of Nottingham. While pursuing her PhD, she won the oral presentation in the opening plenary session at the 2019 EULAR Congress in Spain, for which she also won a travel bursary. In the last year of her PhD, she started working as a research assistant with Dr. Kaushik Chattopadhyay's research team. Currently, she's working with Professor Richard Hubbard, Professor David Baldwin, and Dr. Emma O'Dowd. Dr. Abhishek also joins us. Dr. Abhishek is a professor of rheumatology at the University of Nottingham, UK, and honorary consultant rheumatologist at Nottingham University Hospitals NHS Trust, UK. He qualified in 1999 from Sid GS Medical College in Mumbai, India, and completed residency in internal medicine from NSCB Medical College in Jabalpur, India. After initial medical training posts in Ryle, Cardiff, and Liverpool, he joined the Rheumatology and General Medicine Specialist Registrar Training Program in Nottingham, UK, 2005 to 2013. Here, he developed a clinical and research interest in crystal arthritis. He completed a PhD on calcium pyrophosphate deposition, CPPD, in 2012. He completed higher specialist training in February 2013, gaining dual certification in general internal medicine and rheumatology. His higher specialist training was interspersed with postdoctoral clinical research fellowship training experience at the University of Birmingham. After completing his clinical and research training in January 2013, he took up a substantive NHS consultant rheumatologist post in Addenbrooke's Hospital, Cambridge, UK, where he worked until August 2014. He moved back to the University of Nottingham in September 2014 when the opportunity arose to take up a clinical academic appointment as clinical associate professor of rheumatology and to pursue his research interests. He was promoted to full professor in August 2020. Apart from crystal arthritis, his other interests include epidemiology of autoimmune rheumatic diseases, osteoarthritis, clinical trials and clinical effectiveness studies using big data, and evidence-based medicine. He has had research funding from the National Institute on Health and Care Research versus Arthritis, the Medical Research Council, and other funding organizations. As you may notice from their biographies, these two authors hail from Britain. And so I want to honor their background by interspersing some references to British culture throughout this podcast. So listeners, let's see if you can pick up 5 of these before the end of the podcast. Please welcome Drs. Kaur and Abhishek. So let's get right into this article. In the introduction, you talk about acetaminophen as the first-line oral pharmacological treatment for pain in almost all clinical guidelines. To those who may not be familiar, what exactly is acetaminophen? Sorry, I'm having trouble saying that word, acetaminophen, and how does it work?
Hello, Dr. Kumar, and thank you so much for having us on this podcast today. We really appreciate this opportunity to be here and have this conversation with you. So, acetaminophen, it is a non-prescription and inexpensive, very widely available as an analgesic and antipyretic medication in most countries. It was first discovered for more than 100 years ago, and it has now been in use for more than half a century. It is present in many formulations like short-acting or immediate releases to long-acting or modified releases. It is also available at any supermarket in the form of tablets, syrup, or capsules. So the very first time acetaminophen was used in humans in 1893, although the discovery of acetaminophen was just by an accident when the scientists, they were looking for the better and safer options in order to reduce fever compared to acetanilide compound that they found earlier. And the spectrum of the action of acetaminophen is quite similar to that of non-steroidal anti-inflammatory drugs like ibuprofen and naproxen. Acetaminophen, on an average, is a weaker analgesic when we compare it to the non-steroidal anti-inflammatory drugs or COX-2 selective inhibitors. However, acetaminophen is quite often preferred because it has a better tolerance. Although it has similarities to NSAIDs, the mode of action of acetaminophen has been quite uncertain. So the most general theory that has been accepted widely is that it works mainly in the central nervous system by blocking the pain signals and help to regulate body temperature, making it effective for pain relief and fever reduction.
Yeah, this is kind of amazing that acetaminophen was discovered in 1893, the Victorian age, and yet we still don't really know the mechanism of action for that. That's rather astounding. And, you'd mentioned about ibuprofen, naproxen, and other types of NSAIDs. It sounds like there's been data that shows generally that acetaminophen is safe vis-a-vis these type of NSAIDs. Can you summarize what the research says and where there are gaps in that evidence base?
Absolutely. So acetaminophen has been there for the longest period, and as we say, it has been considered a better and safer option when we compare it to NSAIDs, especially in the older population or those who are contraindicated to take NSAIDs because there has been risk associated with NSAIDs like stomach ulcer, kidney, or cardiovascular diseases. However, there are different aspects to look at when we talk about acetaminophen. So, firstly, I would like to mention here the mechanism of action of acetaminophen. As I said earlier, that its mechanism of action is still an open debate because some of the experimental studies they have suggested that it does not inhibit the peripheral COX enzyme, which rather support the reputation for acetaminophen being as the safer option when we compare it to NSAIDs. However, this is why it has remained the go-to choice for certain groups like pregnant women or those who are contraindicated for NSAIDs or opioids. Whereas the new experimental studies have suggested that acetaminophen can cause COX-dependent side effects which are quite similar to NSAIDs and challenges its perceived safety notion. So it is because that the research indicates that its effect on COX enzyme could be tissue dependent, affecting both central and peripheral pathways. This is where the discussion raised new concerns about the COX-related side effects that were once thought to be minor. Secondly, we know that osteoarthritis is a growing healthcare burden, particularly for the adults over 45, which causes chronic pain, physical impairment, and reduced quality of life. Because long-term pain relief is often needed in such cases, and the clinical guidelines have recommended acetaminophen as the first-line treatment, despite its limited effectiveness. So when I say limited effectiveness, it means that the evidence from the meta-analysis and network meta-analysis of the clinical trial have identified that acetaminophen provides only a minimal or short-term pain relief. Also, the observational data has also consistently shown that NSAIDs and the other pain reliefs are more effective on pain compared to acetaminophen. So because of its minimal effectiveness on pain, the National guidelines in the UK, which is the National Institute for Health and Care Excellence, in their 2022 version of updated guidelines, they suggested that for the people with osteoarthritis, there is no strong evidence supporting that acetaminophen could provide a significant pain relief. While it is often recommended as a first line of treatment, and the research has suggested that its benefits are minimal compared to the other option. Lastly, the safety data that has been provided is also quite controversial. So, the evidence from the randomized controlled trial has suggested that acetaminophen is safe compared to placebo and causes fewer gastrointestinal side effects than NSAIDs. However, these trials they have highly selected population which has a very short follow-up periods, whereas the observational studies they have raised the concerns and have suggested that acetaminophen may increase the risk of gastrointestinal, cardiovascular, or renal side effects, which contradicts the idea that acetaminophen has always been the safer choice. So the results from both the study design in regards to the safety are quite debatable. Despite the widespread use of acetaminophen for acute or chronic conditions, its side effects with long-term therapeutic use have been questioned due to risk and benefit issues indicating a knowledge gap. That is why we conducted this observational study that could help us to contribute to the ongoing debate over the long-term safety of acetaminophen.
Sure. And Dr. Abhishek, would you like to add something?
Yeah, thanks, Jaspreet, and thanks for having us here today. I just wanted to add that the usual perceived notion in medical school is that paracetamol is as safe as air and as sunshine, and as long as you don't have more than 4 grams a day and you don't poison yourself, it's perfectly safe. And I think that's where the we are trying to address some evidence gap, and others have also done similar work before us. And what we are saying is it is not as safe as generally perceived to be, and there are some risks associated, which again have been reported by other people. And the key thing for practitioners and healthcare professionals and patients is to be aware of the risks and the benefits. So if there is a very small increase in risk of a small magnitude, well, it's worthwhile being aware of it. And typically speaking, the hazard ratios of COX-related side effects for NSAIDs are larger than for paracetamol. So, if one would imagine it probably has got lower side effect profile than NSAIDs over a long period of time. But for sort of short period of time, it's perfectly safe. The other thing to mention about using osteoarthritis, where the NICE guidelines nowadays recommend not using long-term paracetamol for pain relief, is the fact that the effect size on pain from a long-term paracetamol in osteoarthritis is very small or insignificant, and most patients stop taking the drug after a while. So what the NICE guidelines here are saying, well, because it doesn't have any decent pain relief benefit and there are potential side effects, don't prescribe paracetamol long-term in people with osteoarthritis, which is slightly different from the ACR and ORC recommendations, where there is a conditional recommendation to use paracetamol for hip, hand, or knee osteoarthritis. So again, it's the key here is that the patient should be made aware of potential risks, and as long as they're judging their quality of life and their own benefit as from the drug as being greater than the potential risk, it's fair to have it for symptom control. So that's what I wanted to add, really.
Absolutely. And we've been kind of giving little sneak peeks of this study that you guys had done. So you'd mentioned about observational studies, about trials, and about meta-analyses and stuff. Can you tell us really how this study that you guys conducted, how has it been different than the previous studies that you had mentioned?
So, as I said, that the previous safety data on acetaminophen comes from the randomized control trial, which are considered as a gold standard when we evaluate the efficacy or safety of any drug. However, these randomized control trials, they have the ethical constraints because they always exclude the vulnerable groups like older people, and they also have cost limitations attached to them, and they prevent the researchers from following the large population over the longer period. So as a result, the safety data, it comes from the post-marketing observational studies. And the observational studies that has been conducted in the past, so when we looked at them, we saw they have faced some channeling bias or confounding by indication. It is a situation where the older adults, those who are at the higher risk of developing gastrointestinal cardiovascular events, they are less likely to be prescribed NSAIDs, and instead they are given acetaminophen, which really makes it challenging to assess the actual risk attached to the medication. So this is we have all of these aspects in our mind when we conducted this study. So firstly, we opted for the observational data so that we can have the longer period of follow-up. So, and then we focused on the adults, those who were aged 65 and above. So this is the group that is most likely to be excluded from the clinical trial. And also this age group is when in the UK, we have the people, they get free prescription, and it makes them less likely to buy acetaminophen over the counter. So this is how our study is different from the studies that had been done in the past in terms of randomized control trial, which have the younger population, and the safety estimates, they come from that population. So then using the literature and discussions with our clinician in our research team like Abhishek and Michael Dorothy, we created a list of potential covariates like age, sex, Charlson Comorbidity Index, and the other analgesic usage based on the probability of having acetaminophen, so that we can add all of these covariates into our analysis in order to make both the groups comparable. And then in our study, we used the advanced statistical techniques like propensity score to account for this confounding by indication bias that I have just mentioned. So we calculated the propensity score and we estimated the likelihood of receiving acetaminophen based on these characteristics. Apart from that, we also conducted a landmark analysis so that we can control for the immortal time bias that usually happens with the observational studies. Then, in order to increase the confidence in the finding, we used 4 different approaches. So we had a 4 set of cohort in our study. So the first cohort was age, sex, and practice matched dataset. Then we have the propensity score matched cohort analysis. And if any of the confounders in this propensity score match study, they were still not balanced, then we added them again to the model. And lastly, we used the inverse probability treatment weighting using propensity score. So this was our main model, given its potential that it will provide us with more precise estimate in the time to event analysis compared to the propensity score matching method. So where we include the whole cohort rather than dropping the individuals as in propensity score matching. So using all of these approaches, we tried to get robust estimates in terms of the incidence of all these outcome of interest for acetaminophen. So in the previous studies, like in the observational data, so they might have like few of these covariates that we have listed in our study. And in terms of the randomized control trial, as I said, they might have the younger population and they might have excluded the population that is above 65.
Just really briefly, you had mentioned just incidentally about the gold standard. And this database that you used was the Clinical Practice Research Data Link, or CPRD Gold. Just very briefly, can you tell us a little bit about what this database is?
So the Clinical Practice Research Data Link, it is one of the largest healthcare databases in the UK, and it is widely used for medical research. So we have like over 736 general practices across the UK that covered 17 million people as of January 2018. So it is the time period that I'm telling you is during the study time period. So maybe after this study time period, more practices have involved and started contributing their data to this database. So what does this database do is it collects the data, like it collects the information about the patient, their demographic information, medication prescribed, diagnosis, the medical conditions, lifestyle factors like smoking, alcohol use, or BMI. So it collects all of these characteristic information for the patient electronically when that patient is visiting the general practitioners. And also it collects the data through the communication with other healthcare professionals. So it provides us with the comprehensive information for the patient. So one of the biggest advantage to have CPRD Gold is because it broadly represents the United Kingdom population, and it makes the estimates highly generalizable to the real world clinical setting. So although originally this dataset was not designed for the research purposes, but over the time, it has become an invaluable tool to study the effectiveness or the safety of the treatment in the real world population. Especially, it is quite beneficial when we are studying the rare exposures or the rare diseases. So the CPRD Gold, it provided us with the rich and the real world data set that helped us to generate the robust evidence, and we were able to inform and we were able to contribute to the evidence-based practice.
Sure. And Abhishek, you have something to say as well, right?
In the UK, healthcare is free at the point of delivery, which means the patients who go and see their GPs, there's no financial constraint. So it's really representative healthcare consultation data. So it's a consultation-based database. The database is also linked to mortality and hospitalization. So cause of death and cause of hospitalization is available for research purposes.
Yeah. And so from what I understand, you'd mentioned 736 general practices, 17 million UK residents, but not all of these people were included in your analysis. How did you decide to include certain people and decide to exclude certain people from this database?
Yeah, so I think you are right. We did not include everybody, like all the patients from CPRD, because it's a huge data set in itself, and it's hard to manage such a big data set. So as I mentioned earlier, we focused only on the older adults. So the people who were above the age of 65 and who were eligible for the free prescriptions from their general practitioner, because normally the prescription is paid in the UK. So it allowed us to study the acetaminophen safety in that cohort because they are less likely to purchase acetaminophen over the counter. And it also, because there is in CPRD, there is no provision to record to have the records if acetaminophen has been bought over the counter. So in order to meet the eligibility criteria for the study participant, they have to be 65 years or old at their index date in our study. When I say index date, so it was the date of the first acetaminophen prescription between 1st of January 1998 to 1st of January 2018. And those participants, they were registered with the general practice for 12 months before their index date. And also, these practices, they were considered to be up to standard by CPRD, which means that they are contributing high quality, complete and continuous data, which we can use or which is suitable for the research. And we have to also make some exclusions based on our study design. So we excluded anybody who already had the diagnosis or who already had the outcome of interest, like gastrointestinal bleeding, hypertension, or chronic kidney disease before the start of follow-up period, because we don't want to include the prevalent cases of our outcome of interest. And this also ensured us that we are capturing the new cases rather than including the people who already have those conditions. So by carefully selecting our study population, we were able to generate more reliable results in terms of the safety of paracetamol in this age group, which is more likely to rely on the long-term pain reliefs.
And Dr. Abhishek, anything else?
Yeah, I just wanted to add that Jasprit mentioned something called prescription charge. So here in the UK, for every prescription you get, you pay a fixed fee of £9.50, which is like $13. And regardless of what's being prescribed. And over a certain age group, the NHS doesn't charge a prescription fee. So when we started the study, over 65s were not supposed to pay any charges for their prescriptions. So that makes them more likely to go and take repeat prescriptions from their GP because it's completely free of cost. So that's one thing which we did to try and reduce any bias from over-the-counter consumption. Yeah, that's the only thing to add, really. I'm sorry, I had one more thing just to add, because this is a prescription-based database. So we don't know if the patients actually took their tablets. So that's a huge caveat which always comes. What we have got is prescribing data. So the GP prescribed it or the pharmacist prescribed it. We don't know if the patient actually took the medicines. So that remains as a weakness.
That's pretty amazing, because at least to me, just as I can't imagine a British home without a kettle. It's hard to imagine a medicine cabinet in Britain without some acetaminophen in there as well. So it's pretty amazing that you've been able to get that population in particular and to have that comparison. So we've talked quite a bit about the methods, and I'm very curious about the results that you were able to get from your study. So what exactly did your results say about the safety profile of acetaminophen in general?
So the results that we have from our study, so using 2 prescriptions of acetaminophen, so we had that it has an increased incidence of gastrointestinal events, cardiovascular events, and chronic renal failure. So if I may say that our study, it has found that we have the increased incidence of peptic ulcer bleeding, which is one of the gastrointestinal outcome. And then we have the hypertension, which is one of the cardiovascular event, and the chronic renal failure. So it is during the study period and with at least 2 prescriptions of acetaminophen.
So was this surprising to you? Did it upend that traditional narrative about acetaminophen?
As I have said earlier, that from the research that has been already done and the experimental studies that has been conducted and that has shown that acetaminophen can have like COX related or NSAID analogous side effects. So it wasn't like a big surprise because it is already there in the literature. But yes, like being, like it has always been the safest, most drug. But now there are risks attached to this medication. So it is a little bit of surprise, but I think it was already there in the literature. So we already knew like there must be something, like there must be some risk already like attached to this medication.
Mm-hmm. And Dr. Abhishek, yeah.
Thanks, Bharat. I think that's a very important question you asked about what our findings were. So essentially, the findings were a statistically significant increase in the risk of peptic ulcer bleed, uncomplicated peptic ulcers, lower GI bleed, heart failure, hypertension, and chronic kidney disease. But I think there are a few things worth bearing in mind here. So although the increase in risk is statistically significant, even the relative increase in risk is quite small in magnitude. So it's the hazard ratios are 1.1, 1.2. It's not a huge relative increase in risk. And if you look at the event rate in our paper, in the exposed and unexposed groups, the difference in the event rate or the crude event rate, even after matching, is not large. So it's a very small. So in real terms, the increase in risk is statistically significant, but the magnitude of the increase in actual risk, not relative risk or actual events, is actually quite small. So I think it's important that we interpret our findings in that context, that yes, there is signal for COX-dependent peripheral side effects, but the magnitude of side effect increase is small. So I just wanted to say that. But otherwise, totally agree with what Jaspreet has said just now.
Absolutely. And of course, this is a podcast, so there's very little visual information. But if you want, you can take a look. Readers can take a look at, figures 1, 2, and 3, and they show these hazard estimates. And if you look at the y-axis, it's actually pretty tiny numbers. For some of them, they're 0.15, 0.08 in terms of this difference. So it helps to provide that kind of context. I also wanted to ask you, and we've kind of started talking about this, so all great scholarly projects, they always have some sort of limitations. What are some limitations that readers should be aware of?
So in regards to our study, so, although the study, it really provided the valuable insights, but also there are some caveats that influence the interpretation of the results. So first of all, I would like to talk about the statistical techniques that we used in our study, which is the inverse probability of treatment weighting using propensity score and the propensity score matching. So we were only able to adjust for the confounders that are there, that are known, that can be measured. So we were not able to account for the unknown or the unmeasured confounders, meaning that there is a still possibility of residual confounding influencing our results. And when we did the propensity score matching, so there were only like 27% of the individuals that we were able to include our analysis. That significantly reduced the sample size. This is when we thought if we can try the inverse probability treatment weighting method, where we have to assign the weights to the individual to make them more comparable. So that allowed us to include all the study participants and produced the consistent findings, so which strengthen the internal validity of our result and make them more generalizable to that group that we included in our study, the older population. And the another big challenge, as we have already talked about, is the over-the-counter prescription. As Abhishek has mentioned, the over-the-counter prescription, like even the prescription of the acetaminophen, so the people, they can take acetaminophen as a prescription or over-the-counter, but we exactly don't know how much acetaminophen was consumed by them. So if I only talk about the over-the-counter medication, it means that we are not accounting for the acetaminophen that the participant that they may have purchased themselves. So in order to minimize this issue, we restrict our study to the individual 65 and above, and they are the people who are eligible for the free prescription in the UK and are less likely to buy it over the counter. However, this might have underestimated rather than overestimating the risk, because those who are prescribed acetaminophen, they are less likely to buy additional over-the-counter medication. So our findings, therefore, they are only applicable to the setting where acetaminophen is primarily obtained through prescriptions. And the another important limitation is how we classified the use of acetaminophen. So because acetaminophen is often used episodically, people, they start taking it, then they stop it, then they start taking it for some different reason. So it could be it could be challenging to define the users versus non-users. So in our study, we defined the minimal exposure, like at least 2 prescriptions within 6 months. So we couldn't track if the participant, they really continue taking the regular or they were intermittently taking paracetamol over the time. Lastly, I would like to mention about the immortal time bias. So it is an issue that arises in observational studies like this. So the immortal time bias happens when there is a period during which the participant is in the exposed group, but they cannot experience the outcome simply because they have not been followed up enough for the outcome. So these are the few caveats in our study. Although the study, it provides the robust evidence about the acetaminophen safety in the older population, however, we also should consider that these limitations are important when we are interpreting the findings, and it also highlights where the future research could lead us in terms of long-term safety of acetaminophen.
Yeah, absolutely. I mean, there's a lot of statistical magic that's within this article, but I really love to hear, especially about the immortal time bias. It's actually one of my favorite kind of biases in terms of statistics. Yes, so this has been very eye-opening for me in terms of what I do in clinic, even though I'm not in Britain and there's a very different context and there's different payment systems, et cetera. This research clearly has not been elementary. So what is next for this project? How are you going to take this to the next level?
So I think because, like I mentioned, that we only captured 2 prescriptions within 6 months, and we analyzed that, like if they can lead to any kind of safety issues related with acetaminophen. What we wanted to do is we wanted to look for the time-varying analysis so that we can capture the episodic intake of the paracetamol. So we can capture that exposure window, and then we can analyze accordingly if that can also have that will provide us the accurate exposure of acetaminophen, and we will be able to produce more precise estimate in terms of the safety of acetaminophen. So this is what we wanted to do, like as a future project. And I think maybe Abhishek can add on to this.
So just to add, I think one could always look at the same results in different data set just to see that they hold from a different country, and then look at paracetamol exposure as a time varying exposure rather than as a fixed exposure, and see if there's any association between any temporal association between prescription and adverse health outcomes. I suppose it would probably be very difficult to get funding for a large clinical trial to evaluate the safety of paracetamol versus placebo. So I think that definitely is out of the box. But more observational studies from other countries' data set and using different analytical techniques so to help increase confidence in the findings.
And I wanted to ask too, because majority of our listeners here are rheumatologists, and we talked a little bit about osteoarthritis. You guys had done a subgroup analysis for the folks with osteoarthritis. Can you tell us a little bit more about that subgroup analysis and what the results were compared to the larger?
Yeah, definitely. So we also conducted a subgroup analysis where we only focused on the participants diagnosed with osteoarthritis in the primary care. So it is a condition which is commonly seen in the older adults and the age group that our study was focusing on. And they often require a long-term use of analgesics like acetaminophen. So what we did, we restricted our study population to the participants diagnosed with osteoarthritis. Then we recalculate the propensity score in order to ensure that the groups, they are well matched. And it helped us to make sure that the participant, those who were using acetaminophen in this subgroup of the people, they were similar as possible to those not using it, specifically in the osteoarthritis group. So we were able to capture, in this way, we were able to capture the true safety of acetaminophen in a condition that frequently leads to chronic pain and regular use of the analgesia. So in our study, if I am not to be like very precise, there were like 115,000 osteoarthritis participant in that study cohort, and we were able to match like 48,000 based on the propensity score, out of which 24,000 were nearly the people who were exposed to acetaminophen, and the other 24,000 were not exposed to acetaminophen. So accordingly, we found that acetaminophen in this study group, it was associated with increased risk of lower gastrointestinal bleeding, hypertension, and chronic renal failure.
Yeah, that's really neat and very methodical in the way that you've done the analysis. Finally, between the two of you, as I looked in PubMed, you've published 162 publications over the last 15 years. And that is very, very, very productive, about one publication per month, along with all the edits, the revisions, and the responses to reviewer number 2. So certainly for either of you, you could say that you are a doctor who is incredibly productive. So can you tell us how much acetaminophen, NSAIDs, or other painkillers do you take?
Thanks for the question, for looking up the publications. They're usually a result of many other people working as teams, and I've been fortunate to be part of many such teams. In terms of your question about personal use of acetaminophen and NSAIDs, I use them for fever, for dental and back pain, and any sort of musculoskeletal pain as I need to. So I don't consume a lot of it, but I do consume short courses of both of those drugs as it's needed. And I think, sort of circling back to our to our work, which was led by Jaspreet, I think what we are trying to do is to produce evidence that will help clinicians and patients make a decision on how they want to approach this drug for their own use.
Yeah, and I'm so grateful for you guys to produce that data, because again, most of this has been received wisdom that it's as safe as air and all of this. And we know that any intake, any exposure is going to have some sort of risks. So I'm very, very grateful for your time and for your effort, Dr. Skar and Dr. Abhishek. And that is all the time that we have for today. So thank you, listeners, for listening to this podcast, and we will see you next time. For those who are tuning in closely for the references to British culture, we had references to Victorian England, to Harry Potter and magic. We didn't talk about this, but peptic ulcer bleeding is pubs, which is very quintessentially British, Sherlock Holmes, and to Doctor Who. So until next time, cheerio. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at ACRoom on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts. Thank you very much.
Thank you for having us.
Thank you so much.